usually in Vivex.
Okay.
Hello, hello, hello. Silence, please.
No, we are ready.
Ready? Great.
You have to do fast because we are running late.
Yeah. Geriatrics, only 10 questions. Very important. See, I will tell you, geriatrics is all about Parkinson disease. I'm telling you. Jo bhi questions.
So for this question, you are allowed 15 minutes only.
Wonderful. So a 68-year-old lady, Parkinson's, Alzheimer's, dementia, these are the things. So she has mild Alzheimer's, comes to clinical review, being accompanied by her husband. She is currently taking donepezil and has some improvement in her short-term memory. Recently, she has begun to suffer from sleep disturbance and waking up very early in the morning. Her appetite has also decreased markedly. She remains in a low mood all throughout the day. Tells her husband regularly that she wants to kill herself. She takes Ramipril for hypertension, atorvastatin for dyslipidemia. Which one of the following is most suitable next step? See, she has depression now.
Yes, sir.
Depression with suicidal tendencies. So you will have to give her very strong antidepressant. Stelopam, fluoxetine, sertraline, valproate. Valproate is anti-epileptic. Haloperidol is antipsychotic. Sertraline and fluoxetine are antidepressants. Citalopram is also an antidepressant, but with a very mild, so I would any day go with citalopram because it is not a very strong sedative. So it is a depressant, but with not very strong sedation. So stelopam may have minor effects on cognition. It is shown to be in Alzheimer's impact positively on patients' mood and well-being, associated with significant improvement in agitation and caregiver. Fluoxetine, they are okay, but they do not elevate mood. So that is the only problem. They are good, but I would definitely go for stelopam because it does not induce sleep. Alzheimer's wala patient, you don't want them to sleep a lot. Then coming to 55-year-old lady with rheumatoid arthritis, treated with methotrexate and etanercept, comes to emergency for review. Husband, 55 is not geriatrics, yeah. She's been diagnosed with influenza in past 24 hours. She's currently taking regular paracetamol and ibuprofen for fever, rigor, dry cough. On exam, she's 120/70, pulse rate is low, chest is clear. Which one of the following is correct plan for influenza prophylaxis for this lady? No prophylaxis needed. Amantadine, oseltamivir, zanamivir, amoxicillin. Her husband has been diagnosed in past 24 hours. So she is on methotrexate and etanercept. Her husband is having influenza, active influenza, and is taking paracetamol. So she wants to know if she can get influenza or not. So the answer is oseltamivir, that is Tamiflu in India. NICE guidelines on influenza prophylaxis recommends prophylaxis with oseltamivir within 48 hours of close contact. In this case, treatment with both methotrexate and etanercept increases the risk of more severe influenza and reduces the effectiveness of influenza vaccination. So we want to start the prophylactic treatment immediately. These amantadine and zanamivir, they are not indicated for, not recommended for influenza prophylaxis. Question number 3. 70-year-old lady admitted with worsening confusion, delirium. Reviewed by a neurologist as a referred case. According to her husband, symptoms got worsened overnight. She is now more agitated with slurred speech and has a slight drooping on left side of her face. She has no longer recognizes him. He tried to hit him as well when he visited her. BP is 115/80, pulse is 82, but with atrial fibrillation. She has a murmur consistent with MR. On physical exam, she has slight drooping on the left side of her face. Some apparent coordination problem affecting left hand side was also noted. Stroke ho gaya isko. The examination has to be cut short as the consultant neurologist, she accuses that he is trying to poison her and tries to spit in his face. Routine tests are unremarkable. What is the most appropriate intervention in this scenario. She's become very aggressive. So what are the drugs for aggressive behavior? Antipsychotics, dopamine antagonists. Which one of them is? Donepezil, Memantine, lorazepam, olanzapine, sertraline. So we give her olanzapine. Okay, Oleans as in India. D, likelihood multi-infarct dementia situation. There are elements of psychosis and the patient is holding a belief that doctor and staff are trying to kill her. So nice guidelines support the use of lorazepam, haloperidol, olanzapine in acute situation. Of course, haloperidol is least preferred because of ataxia. A 55-year lady, again she's young, reviewed by the cardiology 1 week returning from a holiday in Greece where she admitted for the hospital with anterior STEMI. She received 2 stents there and has now recovered well with no subsequent chest pain. So no post-MI angina or something like that. No post-MI LVF. On exam, BP is fine, pulse rate is good, it is regular, chest is clear, ECG has anterior Q waves. Which one of the following drug combination would advise to her as an antiplatelet therapy? How much? 1 week after returning from holiday. Okay. So, what is the DAPT? DAPT is dual antiplatelet therapy. This is observed in cases who have been stented. जिनको कार्डियक स्टेंट पड़ जाता है, उनको डबल एंटीप्लेटलेट्स देते हैं. The data is there for 3 months DAPT and 1 year DAPT. You will have to go through that data. Although 1 year has got higher incidence of bleed, but also is having better against stent thrombosis, delayed stent thrombosis. So, what would you like to give? She doesn't have atrial fibrillation. He's doing well. Aspirin, clopidogrel, aspirin daily, aspirin plus clopidogrel, aspirin daily, and ticagrelor twice daily. So what is the answer?
E, sir.
E. So if aspirin is to be combined with clopidogrel, the dose will be aspirin 150 and clopidogrel 75 BD. But if you are giving ticagrelor combination, then 75 milligram 1 daily and ticagrelor 90 2 times a day. So the answer is E. So this is to be continued for at least 3 months. Okay, because of this patient now has a stent. All right, 5th question. 26-year-old gentleman. Come on, this is geriatrics. So basically, this is about the question about a gene related to Alzheimer's disease. So the answer is SEN1, PSCN1. Mutation in pre-senilin-1 accounts for 50% cases of familial Alzheimer's disease. So that is why it is important. Okay, PSCN1 is basically pre-senilin करके एक protein रहता है, उसकी gene है PSCN1. A 61-year-old lady suffered multiple previous myocardial infarctions, comes to cardiology clinic for review. She has symptoms consistent with class 3 heart failure. Current medications are ramipril full dose, bisoprolol full dose, furosemide full dose, aspirin 75 milligram daily, and atorvastatin full dose. She still has symptoms of shortness of breath. Heart failure की दवाइयाँ कौन-कौन सी हैं? Ramipril, cardioselective beta blocker, okay, bisoprolol, and furosemide. What else you can add to this patient? That would be the question. Ejection fraction is 31%. So 30. So this is heart failure with reduced ejection fraction. She's already on ACE inhibitor. She's already on beta blocker, which is cardioselective, and she's already on diuretics. So what would you want to add?
C.
She's already on ACE inhibitor. She's already on ACE inhibitor. See, the options should ideally be nitrates, the combination of nitrate and hydralazine, that is isolazine. And in case she can be stopped ACE inhibitor for 72 hours, she needs to be shifted to 𝐼. 𝐼 is valsartan-sacubitril combination. So now this is the drug which is superseding the ACE inhibitors for the treatment of heart failure with reduced ejection fraction in the European guidelines also. But if you are unable to do anything, then you put in a CRT, that is cardiac resynchronization device, with, of course, in this case, heart rate is 66, but the EF is 31%, less than 35. So you would want to add a defibrillator to it. So you can add ivabradine, but it will just increase the, it decrease the heart rate even further. She has 66. Implantable cardiovascular device. She never had a VT directly. You want to prevent it. I think I would go with cardiac resynchronization therapy with defibrillation. At least this is the advisable. But ivabradine being there could also be an option. Let's see what the answer says. So the answer is just B, that the patient needs implantable cardiac defibrillator, but it will not improve the heart failure symptoms. ICD is the only recommended option for VT and ejection fraction of less than 31 and symptomatic heart failure. CRTD is having patient with LBPB with prolonged QRS. Come on, man. The QRS, what is the duration of QRS? Let's see. Okay, they've mentioned 125. So beyond 160, we have to add CRT. So that means a dilated heart. As of now, the CRT will not be indicated because of the QT interval. Oh, sorry, QRS interval. So if the QRS is more than 150, only then we consider CRT. Otherwise, defibrillator, they are correct. They are absolutely right in this. Fair enough. So CRT will any day be recommended in patients with prolonged QRS more than 150. Our patient has still 127. So you can, and then you can always upgrade the ICD to ICD, CRT, DR. All right. It was more technical cardiology question actually. So, but be ready for such questions in exam. Ivabradine is also recommended in patients, but who are tachycardic with heart failure. So our patient is not tachycardic. She has heart rate of 66. But if I'm telling you, there could be an option that stop ramipril for 3 days and put the patient on valsartan-sacubitril. That would be a better option as of now. A 70-year-old man with 15-year history of bipolar disorder presents to endocrine clinic. Why bipolar person comes to endocrine clinic? He diet includes lithium, olanzapine, past 3, 4, polyuria, polydipsia. So this is basically lithium induced. So how will you work up this patient? Say again.
We will send osmolarity, urine osmolarity, serum osmolarity.
उससे भी पहले कुछ करेंगे आप? So polyuria means diabetes.
Yes, sir.
So check blood sugar.
Yep.
Check sodium. So if the sodium is high, check the osmolarity. If osmolarity is also high, you check urinary osmolarity. So if the urinary osmolarity is decreased, that is dilute urine with hypernatremia, hyperosmolar status, you water deprive the patient. If after water deprivation, the patient's urinary concentration does not happen, urinary osmolarity remains low and the serum osmolarity remains high, then you give them injectable ADH, DDAVP. So if after giving DDAVP, the urinary osmolarity starts to increase and the serum osmolarity starts to decrease and the serum sodium starts to decrease, that means the patient has central diabetes insipidus. What will happen to this patient? He has a lithium-induced nephrogenic diabetes insipidus. So even if you give DDAVP to this patient, their osmolarity will not change. Their osmolarity will not change. Okay? So what will you give them? In lithium-induced diabetes insipidus, the treatment is either it is tetracyclines. or it is thiazides. Exactly. Or is it? Or it is thiazides. Perfect. So I just taught you water deprivation test also, although the question was not about it. Let's see what the question is. So we have a patient of lithium-induced diabetes insipidus because it showed no significant change after DDAVP. So this is nephrogenic diabetes insipidus. Which one of the following is most likely cause of clinical picture here? Reduced GSK3 beta signaling, reduced production of ADH? No. Hyperfunctioning of aquaporin 2? No. Reduced functioning of SGLT1 or activation of SGLT2? ये भी नहीं है. तो इन्हीं में से दोनों में से कोई आंसर है? Any guesses? Okay, so the answer is A, that is reduced GSK3 beta signaling. So lithium inhibits the signaling pathways that involve glycogen synthesis. So lithium does not allow the kidney to tell the system that I don't need to excrete more urine. So that is through GSK beta 3 signaling. All right. So this results in dysfunction of the aquaporin 2 water channel. So no matter how much antidiuretic hormone is available, it will still not lead to any significant concentration of the urine. This is Alzheimer's again. Okay, this is osteoporosis. So 67-year-old lady with recurrent fractures presenting to rheumatology clinic. BMI is 20. She's pretty thin. She has been prescribed residronate for bone protection, but she states that she has suffered from increasingly severe reflux over the past few months because of residronate. Which one of the following is most appropriate intervention for the osteoporosis of this lady? Her sodium is fine, potassium is okay, creat is very high, 2.5. GFR is very low, so 27. So she is 15 to 30 creat clearance. So that means she is stage 4 CKD. Serum calcium is 2.28, which is fairly okay. Alkaline phosphatase is normal. And parathyroid hormone is also, it's slightly elevated. So what would you want to give to this patient? Her calcium is okay. Denosumab, teriparatide, zoledronate, calcium and vitamin D. So calcium is fairly okay. Raloxifene. How about the A, denosumab, which is a rank ligand inhibitor? It is basically a specific treatment for osteoporosis. It is basically osteoclast inhibitor. So it is given by a subcutaneous injection every 6 months, and it comes free in NHS. So it is given to elderlies where bisphosphonate therapy has caused problems. So if the patient has caused trouble and patient cannot adhere to bisphosphonates, then you will move to denosumab, which is basically a chimeric product, just like biological therapies like infliximab and all those drugs. So this is denosumab. Moreover, these drugs like zoledronate, they are not recommended in GFR less than 30. So that is another thing why we want to give denosumab. Okay. This is last question. A 70-year-old man found wandering on the street. Police has got this patient to you with suspected delusions and paranoia. The patient is very aggressive and wants to go home. What does section 5/2 of Mental Health Act allow a physician to do if mental health illness is suspected? So please go through the Mental Health Act. There are only 2 clauses in it that you can actually, as a station head officer, SHO of your hospital, you can detain a patient if you feel that they are at a risk of causing damage to themselves or to public property with their harm. Then you can actually do that. So the answer is that you detain this patient for 72 hours if they're already being nursed in a hospital. Section 5/2 of Mental Health Act allows the physician or a surgeon to detain a patient. Detain means you can arrest and keep them in the lockup for 72 hours if they are already being nursed in a hospital where they are suspected or having worsening mental illness. So please go through some important things. One is the Mental Health Act. The other is the DLI, the driving license instructions. Okay. So after stroke, after MI, after PT CA, after CABG, after seizure, after encephalitis, after status epilepticus, after starting insulin to a patient who is hyperglycemic, who is diabetic. So there are so many things that you have to DVLI. So this organization is a driving vehicle licensing institution. So their guidelines you have to read before you go for exam.
So what is the second part of the mental health act? Second important clause?
Second important clause, just two clauses. One is that you detain a patient. I mean, if the patient is already under treatment, you can detain the patient for 72 hours. Otherwise, if within 24 to 48 hours, if the patient has come to you in the hospital or in the acute your emergency, and you feel that they are damaging, you can call the police. You can call the police. You cannot detain a person who's not admitted in the hospital, who has just come to the emergency brought by the police. You can tell the police to stay there as long as the patient is not fit to be discharged, because the patient is in emergency. They have just come now. So you have no right to detain them, because you need to investigate them. So you need the help of police there.
It's an 8 question thing, just revise 8 question
So it is not about the question. If you look at the options are very clear, that you just have to pick out the right answer. The right answer is that you can detain a patient for up to 72 hours if they are already being nursed in a hospital. Their other options were detain a patient for up to 24 hours in emergency. No, you cannot do that. Detain a patient for up to 48 hours in the emergency. No, you cannot do that also. In UK, the principle is that in emergency, you keep the patient only for 24 hours. And after 24 hours, you shift the patient under the acute medicine care. And there they keep the patient for 48 hours or 24 to 48 hours. And then they decide in which department the patient will go. So they have this mini ICU kind of a situation, which is acute care. So the patient, in the emergency, you cannot keep the patient for more than 24 hours. So what will you do if the patient is aggressive for 24 hours? You will actually tell the civil authorities about the patient who is aggressive, and they will, lot of police involved, and there is a convener involved as well. So for the first 24 hours, if you want to keep the patient in the emergency. Otherwise, you cannot.
8 questions or 8 question answers. 8 questions. Question number 8.
Say again, I could not hear.
Alzheimer's, 8 question. 8th question. Alzheimer's. Question number 8. Appropriate intervention for the Alzheimer's. 70-year-old.
Okay. So we left that question. You want to do that?
Yes, sir.
Okay. A 70-year-old gentleman attends the memory clinic with his wife. He has retired from his job as a legal advisor some 4 years ago because he was finding it difficult to keep up the pace of work. Over the past few months, his wife has noticed the deterioration in his short-term memory. He keeps on losing items at the house. His wife puts things in the kitchen. When challenged about this, he becomes agitated. He has a little sleep disturbance and tends to wake up early in the morning. So sleep has also got affected, and sleeps in a day. He has no significant past medical history of note, except hypertension, for which he is already taking Remiprid. By appearance, he looks confused. He looks a little disheveled. So general physical examination is 130/80 is blood pressure. He's unremarkably. He doesn't have some memory impairment with a mini mental state examination score of 21/30. It is fairly okay. And MRI suggests an underlying Alzheimer's disease. So which one of the following is the most appropriate intervention for this patient? So see, you have to identify what problems he's come to you with. His MMSC is 21/30. It should have been 30 for a normal person. So it's 21/30. His problem is that he is having problems with short-term memory. And he's not dressing well. He's unable to sleep at night. So sleep disturbance is there. So let's write down the chief complaints. He keeps on losing items around the house because of short-term memory. He puts them into odd places. When challenged about this, he becomes agitated as well. He gets irritated because he feels that I am being bothered unnecessarily. He has sleep disturbance. Okay, so in any day, I would like to start this patient on a donepezil. We have options of Memantine, Risperidone, donepezil, sertraline, zopiclone. So for memory loss, short-term memory, he's a lawyer. He's a lawyer, no? He's a gentleman memory clinic, legal advisor, yeah. So you can start this patient safely on donepezil. Okay, yes, which is an acetylcholinesterase inhibitor. This gentleman has a significant cognitive impairment with MMSE of 21/30. Such NICE supports the use of an acetylcholinesterase inhibitor, which is donepezil, galantamine, and rivastigmine. They do not impact the disease progression, but they may improve functioning to reduce care needs and enable the person to remain in their homes for a longer period of time. Memantine is only recommended in severe Alzheimer's, where the patient cannot tolerate donepezil. Risperidone is not indicated. Risperidone is an antipsychotic drug. In addition, there are no clinical features of depression, so sertraline ki zarurat nahi hai. Sedative, zopiclone, they will actually increase the problems of this patient. He will be confused more with sedative drugs. So the answer here by all justifications would be donepezil. Anything else?
Thank you.
So please go through the MMSC ones.
Yesterday's genetics. I think you probably won't have time for that. We'll go for the Robin Ray.
See, if you want to see the MMSC, you can see it here. I'll show you. You can see the screen. So basically, MMSC is very, very helpful in deciding on whom to treat and whom not to treat. All right?
Yes, sir.
So these are the questions. Like 5 questions, 5 score is given to what is the year, season, day of the week or month. Where are we now? State, country, town, city, hospital, floor. The examiner named 3 unrelated subjects clearly and slowly. So the number of marks is important. Anywhere, we all should have a 30 score. All of us. But as the number decreases, the severity increases. 25 to 30 is very mild problem. 25 to 30 is very mild problem. But as we start going below, from 20 to 20, it is moderate. Below 20 is severe. So if you want to start Memantine to your patient, the patient has to have a MMSC score of around 15 to 16. Is that clear?
Yes.
So this is the importance of MMSC. And believe me, it is not very difficult to understand.
We'll probably take a break now. I think our next speaker, Dr. Robin Ray, is already online. So thank you very much for your help, and it's a very informative session.
Thank you very much. Thank you. All the best, guys.